Our next presenter is Dr. Matthew Taylor, and I will introduce him as a true left coaster. Dr. Taylor attended medical school at Oregon Health and Sciences here in Portland, and then headed up the I-5 corridor to do his internal medical residency at University of Washington. The great weather in Portland brought him back to do his fellowship at OHSU. And now he is here working with our melanoma program at the Providence Cancer Institute. Dr. Taylor, take it away.
Okay. Thank you, Chris, for the kind introduction. And thank you to the organizers for inviting me to speak with you today. So I'm going to be talking today about some adjuvant and neoadjuvant therapies, and I'll explain what these are. And for the most part, we're talking about melanoma that has been diagnosed in somewhat of an earlier stage when it's confined either just to the skin or has spread to regional lymph nodes. And we'll talk about what this means. So let's see if I can get this to advance. There we go. These are my disclosures. So first of all, let's just start with some terms. So we're going to talk about adjuvant and neoadjuvant. So adjuvant therapy is the term that we use to describe treatment that is given after surgery to remove the cancer. Neoadjuvant treatment is the term we use to describe giving some kind of medication or treatment, could even be radiation therapy, but some type of treatment that is given before surgery to remove the cancer. And we'll talk about why this is an important way to treat cancer. So just to level set, I first wanted to just talk about what is the current standard of care? What are the medications that we use? What are the options that are available to us? So if someone is diagnosed with melanoma today, what do we have that's approved by the FDA that we use routinely in the clinic? So I've broken this down by different stages of melanoma. So if someone is diagnosed with stage 2B or 2C melanoma, that means it's a relatively thicker melanoma, but it's confined just to the skin where it started. It has not spread to lymph nodes in the vicinity. It has not spread into the lungs or the liver. That's a stage 2B or 2C melanoma. So patients that have undergone surgery to remove that melanoma tumor are then eligible to be treated with 1 year of immunotherapy with an anti-PD-1 drug such as pembrolizumab or nivolumab, known as Keytruda or Opdivo. If the melanoma is more advanced, if there's stage 3, meaning that the melanoma has spread from where it started in the skin to one of the regional lymph nodes, these patients, after undergoing surgery to remove the tumor, as well as a sentinel lymph node, or even if the lymph node is obviously involved with cancer on a PET CT or a CT scan, after surgery to remove that melanoma, these patients are also potential candidates to receive immunotherapy with a drug like pembrolizumab or nivolumab. Similarly, for stage 3 melanoma patients who have a mutation in a gene called BRAF, about 50% of melanoma patients will have a mutation in this gene. Those patients could be treated with what we consider targeted therapy. These are pills that target this mutated gene within the melanoma. So that's another option for patients, in addition to what they could either receive immunotherapy or the targeted therapy for the BRAF gene mutation. And lastly, on the right, patients with stage 4 melanoma, meaning the melanoma has spread from where it started and traveled to the lungs or the liver. After undergoing surgery to remove melanoma tumors, these patients can also be treated with adjuvant immunotherapy with nivolumab. So those are the current standards. That's what we use in the clinic every day to treat patients who are diagnosed with melanoma at these various stages. And what I'm going to share with you today is some exciting research that's been evolving over the past several years that really is going to change how we treat patients in the future with melanoma. So just to kind of review some of the clinical trial data, and we'll try to not get bogged down into the weeds, but just to provide a bit of a background for why do we use these therapies and why are they helpful. So this is from the Keynote 54 clinical trial. So this was for patients with stage 3 melanoma, and these patients were put into two groups to either receive pembrolizumab or a placebo infusion. And what this clinical trial showed was that patients who were treated with pembrolizumab, depicted in the blue line, these patients did much better than patients who received a placebo. There was a greater percentage of patients who were cured from the melanoma. There was a less risk of recurrence of melanoma in the patients treated with pembrolizumab. So this was one of the early trials that really demonstrated that patients with stage 3 melanoma, after having undergone surgery to remove the melanoma, should be treated with adjuvant immunotherapy. And this is a clinical trial that looked at treating a similar population of patients. So patients with stage 3 melanoma who had undergone surgery to remove the melanoma. To qualify for this trial, these patients had to have a known mutation in the BRAF gene within their melanoma. So these patients could be treated with these pills called dabrafenib and trametinib, or Taflunar and Mekinist. And so they were treated with these pills for a year. And the clinical trial data here is also very impressive and very similar. If we look at the curves, that at 5 years, patients treated with these pills did better than patients treated with a placebo. And so again, this was very strong evidence that treating patients with pills targeting this BRAF gene mutation, this can be very successful, very effective in reducing the chances of the melanoma coming back again after surgery. So this led to the approval of these drugs for patients with stage 3 melanoma with the BRAF gene mutation. So based on the success of treating patients with stage 3 melanoma, we then did clinical trials with patients at an earlier stage, looking at patients with stage 2B or 2C melanoma to see if offering these patients immunotherapy after surgery is beneficial. Does this help reduce their risk of recurrence of melanoma? And in fact, the answer was yes, it does. So in this figure, we're again showing patients either treated with pembrolizumab in the green line versus a placebo in the purple line. And what this figure is demonstrating is that patients treated with pembrolizumab after surgery to remove stage 2B or 2C melanoma, these patients have a decreased risk of recurrence of the melanoma. So this also led to the approval of these immunotherapy drugs for patients with stage 2B or 2C melanoma. So now I want to tell you about a clinical trial that we've been a part of for a number of years that's been very exciting, and we fully expect this is going to change the way we treat melanoma in the future. And I'll just start with a little bit of the background of this. We started working with a company that was known to very few people at the time by the name of Moderna. So this was back in, I believe, 2017, maybe 2018. And this company, Moderna, was making mRNA vaccines to treat cancer. And it wasn't until the COVID-19 pandemic that this company, Moderna, decided they would make vaccines for the COVID-19 virus, that now Moderna is a household name. But the same company they had their roots in making vaccines to treat patients with cancer. So the way this vaccine works is really quite interesting, and what this is. So what happens is patients would have a biopsy of their melanoma that would diagnose their melanoma, and then this melanoma biopsy specimen gets sent to Moderna. Moderna then processes the tumor and tests for different, to find out which genes are mutated within their cancer. And based on the genes that are mutated, they then generate an mRNA vaccine that is unique and specific to that individual only. So each vaccine that is made is basically a custom vaccine for the individual with that cancer. So this is not a vaccine that they can make a ton of them and put them on the shelves and just take them off the shelf and give them to anyone. Each vaccine is custom made for the individual, that is based on the mutations within their cancer. So in this clinical trial, patients with stage 3 melanoma or stage 4 were randomized to either get the current standard of care, which is pembrolizumab. So undergo surgery and then get adjuvant treatment with pembrolizumab for a year. That was the standard that it was being compared with. Or patients would receive pembrolizumab in combination with a vaccine that has been this mRNA vaccine that is a custom fit for their particular cancer. And this is the Kaplan-Meier plot. This is the way, as you've been able to see, this is the way we like to present a lot of data showing the recurrence-free survival. So what percentage of patients are still alive and well and have not had a recurrence of their melanoma? And what you'll see is patients treated with pembrolizumab in combination with this vaccine called mRNA 4157 did much better than patients who were treated just with surgery followed by pembrolizumab by itself, which is still, as of today, one of the current standards. So this was very exciting to see that the addition of this personalized tumor vaccine can really improve the benefits of immunotherapy and reduce the risk of recurrence of melanoma. So this has not yet been approved by the FDA. The clinical trial is ongoing, but we are all anxiously awaiting the approval of this therapy because this really seems to improve upon the current standard of care. So let's pivot now and talk a little bit more about neoadjuvant therapy. So again, the reminder, neoadjuvant means we're giving some kind of therapy before doing the surgery to remove the bulk of the tumor and remove all of the melanoma that's present. And so why would we do this? Why would we give a therapy before we do surgery to remove the cancer? So it's interesting to point out that the majority of what we call tumor reactive T cells, these are the immune cells that can recognize and fight and attack the melanoma. The majority of these T cells are found within the tumors, as well as within the draining lymph nodes that are near the tumor or within a lymph node metastasis. And so the cells that we want to activate to be able to fight melanoma are actually already in the tumor. So if we undergo a surgery and remove the tumor and remove the lymph nodes, yes, we're getting the melanoma out, but in effect, we're also removing a significant percentage of the T cells that can actually see and would have the ability to fight and attack the melanoma. So with this concept in mind, if we can treat patients with immunotherapy before they undergo surgery, we have an opportunity to activate those very important T cells that are recognizing the tumor before the tumor is surgically removed. So this gives us the best chance to activate the immune system to fight the cancer at an early time point. So I'll share with you this clinical trial. This is called the SWOG S1801. This was a clinical trial in which patients with stage 3 all the way to stage 4 melanoma who were candidates to have surgery to remove all signs, all evidence of melanoma. These patients were randomized to either undergo surgery and then get 1 year of adjuvant pembrolizumab, again, as the standard of care, or to receive 3 cycles of treatment with pembrolizumab before surgery, and then to continue to get 15 more cycles of treatment. So it's basically giving the immunotherapy a little bit before surgery and then 15 cycles after surgery. And what you can see from the figure here on the right, patients who were treated with pembrolizumab before and after surgery did better than those who immediately underwent surgery and were then treated with pembrolizumab. So this was very exciting to again see that we can improve upon the current standard, we can do better, and we can help reduce the risk of melanoma coming back in these patients with locally advanced melanoma. This is another clinical trial called the NADINA study, and this was, again, looking at the same concept. If we give immunotherapy before surgery, can we improve outcomes? So in this clinical trial, different medications were used, and so the control arm is depicted with kind of the orange bar there, where patients with stage 3 melanoma would undergo surgery to remove all signs of melanoma, and then they were treated with 1 year of nivolumab, excuse me, 1 year of nivolumab immunotherapy. That's one of the current standards of care that we use for this disease. And then in the investigational arm of the study, patients were treated with 2 cycles of ipilimumab and nivolumab, also known as Yervoy and Opdivo. This is a regimen of immunotherapy that we use frequently for patients with advanced metastatic stage 4 melanoma. So these patients were given 2 cycles of this treatment. Then they underwent surgery. After surgery, they would look to see what was the result, what was the outcome. And so if all of the tumor or a significant amount of the melanoma had been destroyed by the immunotherapy, that was it. That was the end of their immunotherapy. They did not need to receive any more immunotherapy after surgery. If they had more of a partial response or they did not respond to the immunotherapy at the time of surgery, then those patients were treated with additional adjuvant immunotherapy, or if they had a BRAF gene mutation, they were treated with dabrafenib and trametinib, BRAF and MEK inhibitors for 1 year. And the purpose of the clinical trial was to see, can this improve on what's called event-free survival? Can this prevent recurrence of melanoma? Can it improve overall survival? And so those were the objectives of the study. So what I'll highlight here is that in the patients who were treated in the neoadjuvant group, meaning they got ipilimumab and nivolumab for 2 cycles, and then they underwent surgery, when the pathologist looked at the specimens under the microscope, they found that 55 to 60% of these patients had undergone a very significant immunologic response in which either all of the melanoma had been completely destroyed or a very significant percentage of the melanoma had been destroyed. So this was a really impressive high success rate for the immunotherapy destroying the melanoma. A smaller percentage of patients, maybe 8 or 9%, had a partial response. And unfortunately, about a quarter of patients had no response. The immunotherapy was not able to activate the immune system to attack the melanoma. So here again is our Kaplan-Meier plot, and this is showing in the blue line the patients treated with the neoadjuvant ipilimumab nivolumab prior to surgery, compared with those who, in the red line, underwent surgery immediately and then were treated with a year of immunotherapy. And so again, this trial demonstrated that immunotherapy given before surgery was very beneficial in reducing the risk of recurrence of melanoma for these patients. So very exciting to see such a significant improvement over our current standard of care. This just demonstrates that this benefit was observed both in patients with BRAF gene mutations as well as melanomas that don't have a mutation in the BRAF gene. This is kind of a busy, clunky slide to look at, but the message of this slide is, and this will come as no surprise, the patients who had an excellent immunologic response, meaning they got immunotherapy before surgery, and at the time of surgery, the pathologist found that almost all or all of the melanoma had been destroyed. These are patients who had an excellent remission from melanoma. And patients who had a partial response to the immunotherapy, their response to the therapy overall was kind of intermediate. And unfortunately, patients who did not respond to the immunotherapy and the melanoma had continued to grow at the time of surgery, sadly, these patients did not do as well. And we need to find better ways to offer effective treatments for these patients. And just to touch on side effects very briefly, the takeaway message is that treatment with ipilimumab and nivolumab given prior to surgery causes more side effects than doing surgery and then giving nivolumab by itself. This comes as no surprise to us. We've known for many years that the combination of ipilimumab and nivolumab causes more side effects than an anti-PD-1 drug by itself, such as nivolumab or pembrolizumab. So this is an irritating slide that I made to try to put several of these clinical trials into one table. And so let's just look at the column titled EFS. This is event-free survival at 2 years. And so if we come down from the top, the S1801, SWOG 1801 study showed that treatment with neoadjuvant immunotherapy was better than doing surgery first and then immunotherapy. If we look at the NADINA study, immunotherapy prior to surgery was better than doing surgery and then giving adjuvant immunotherapy. And then the next line, the mRNA 4157 and pembrolizumab, that study was purely an adjuvant study. It was only after they'd had surgery to remove the cancer. And so we don't have the same neoadjuvant to adjuvant comparison, but we have a very impressive 77% of patients having no sign of recurrence of melanoma at 2 years. And then there's another clinical trial that I didn't mention previously, which is a combination of 2 drugs, one called relatlimab, the other nivolumab. This combination is known as Opdualag. And so patients treated with this Opdualag therapy prior to surgery to remove the melanoma, these patients had an 80% event-free response. So the message is, we've seen lots of different approaches to improve upon what the current standards of care are for treating melanoma. And we're excited to see these things get approved and enter general use in the clinic. I want to show just a brief case report of one of my patients. So this is a 64-year-old gentleman, Southern Oregon. So he had a pigmented lesion, a dark spot on his back, had a biopsy done, and this was demonstrated to be melanoma. And so he had surgery at the time to remove, he did not have a wide local excision or sentinel lymph node biopsy, just an initial biopsy at the time. So that was not the standard of care. That was poorly done. Unfortunately, 2 years later, he shows up to see his doctors in Southern Oregon and is found to have a large mass in his armpit. So he has a PET scan, which showed this bright yellow mass in the left side of your screen. That's his right armpit. And so a biopsy was done, and that was shown to be melanoma. So he basically had melanoma that had recurred 2 years after his initial biopsy. And so at this point, he got referred to come talk to me about what we should do about this. So based on the NADINA study and the results showing the benefits of doing neoadjuvant immunotherapy, I recommended that we treat him with 2 cycles of ipilimumab and nivolumab. And so he got that treatment. And then he went and had surgery to remove the lymph nodes from his armpit. And at the time of surgery, when they sent this to the pathologist said that all the melanoma was dead. There was no viable residual melanoma at all. So he's a patient who had a complete pathologic response to just 2 cycles of immunotherapy. Unfortunately, he developed some bad side effects from the treatment, in which his immune system attacked his intestines and caused some severe diarrhea, and he was treated with prednisone, and the side effects resolved. So I just highlight this to show that this happens not just in the clinical trials, but this is something that is happening and helping our patients today. So to conclude, neoadjuvant immunotherapy, again, immunotherapy given prior to surgery, has a very high rate of pathologic responses, meaning this can really help the immune system become activated and fight and destroy melanoma prior to surgery. Neoadjuvant immunotherapy in what I'll call macroscopic stage 3, meaning that you can either feel that there's a lymph node or you can see that there's a lymph node that's enlarged on a PET scan or a CT scan. That's what we would consider macroscopic stage 3. For those patients, neoadjuvant immunotherapy is better than our current standard of doing surgery first, followed by adjuvant immunotherapy. And fortunately, we didn't see any surprises with side effects from neoadjuvant immunotherapy compared with adjuvant immunotherapy. A couple of unanswered questions. We now have an embarrassment of riches of data from several different clinical trials with different medications, all showing improvements in our current standard of care. So what is the best form of neoadjuvant immunotherapy? Is it pembrolizumab by itself? Is it the combination of ipilimumab plus nivolumab? Is it the combination of relatlimab and nivolumab, that one called Opdualag? Or is it this triplet regimen of pembrolizumab plus the BRAF and MEK inhibitors? And we don't know yet which of these is the best. They've all shown positive results. We also don't know where is this Moderna vaccine going to fit in with this. We know that this Moderna mRNA 4157 vaccine in combination with pembrolizumab is very effective and is better than doing pembrolizumab by itself. So this begs the question, will we just give this after surgery? Will there be a situation in which we might give some immunotherapy prior to surgery and then after surgery treat with immunotherapy plus the personalized tumor vaccine? So we still have a lot of work to do to sort out these questions and understand what is the best way to treat earlier stages of melanoma. But it's very exciting to see how quickly progress is being made and how new therapies are impacting the lives of our patients. And with that, I will conclude my remarks.